conversations and to share knowledge across continents and across divides of expertise. So we've just joined our live streams, Facebook Live, YouTube Live, and Twitter Live. And so let's get the show on the road. Welcome to the Nonprofit Report, your update on nonprofit organizations, issues, and leaders. I'm your host, Mark Oppenheim. Today we're discussing some of the integrated and multi-sectoral approaches that address the most critical health challenges affecting the Global South with special guests. Traci Baird, President and CEO of EngenderHealth. Dr. Mesfin Teklu Tessema, the Senior Director of the Global Health Unit of the International Rescue Committee, and Dr. Cherian, Associate Vice President of Global Health and Nutrition of Corus International. I'd like to thank you all for joining us, and a reminder to Zoom attendees that we take 3 snap polls during the show. We'll announce results, and your questions submitted through the Q&A function at the bottom of your screen will be included in our discussion. So it's great to have you here. Thank you so much. As I said a little bit before the show, I always feel like my role is to be the perennial student, listening and learning from people who are way smarter than I am. So I want to set you up. We're going to go to Traci. Just it's so stunning that over 10 million people in the Global South annually die of easily preventable illnesses. And that number is dwarfed by the number of those suffering from persistent malnutrition, disease, hunger, lack of shelter, lack of access to water and sanitation, and lack of access to basic health care. So Traci, let's just start with you, just sort of on an orientation, and then we're going to go around the room. Your organization, EngenderHealth, places gender equity for women and reproductive rights at the center of the struggle for health in African countries and in India. Why do you do that? Why are women at the center of that effort?
Well, thanks, Mark. It's great to be here and wonderful to be with Mesfin and Dennis. I'm big fans of IRC and Corus, so I think this is a lovely conversation to be part of. And you said in your introduction that these are multi-sectoral, integrated, tightly interwoven issues. And EngenderHealth, with the work we do globally on sexual and reproductive health and rights, on maternal health and addressing gender-based violence, we see gender and gender equality issues as something that cross-cuts all of these topics in health globally. I know we're talking about the Global South, but the Global North is not off the hook either. But one of the things that we see is that, when we have the majority of the global health workforce being female and half of the world's population being female, yet most of the decision makers about global health policies and practices being male, we also see that there's already an inequity built into the system until we can shift the leadership balance. And we see the impact of gender on every health topic that we work on, and probably IRC and Corus do as well. For example, with one of the areas where we're working in an intersection is the intersection of maternal and reproductive health, nutrition, and gender. And we know that when women have poor nutrition in pregnancy, their infants will be low birth weight and have a lot of trouble catching up. We know that girls with poor educational status have trouble staying in school, which increases their risk of early pregnancy and violence. And we know that women, even though many are responsible for the nutritional status of their family, don't have the power to negotiate at the household level, the community level, or the food sector level that men do. So if we don't start unpacking these issues around gender, we will never fully be able to realize all of the wonderful solutions and strategies we have in global health. So we are always looking at how we can involve men in reproductive health, which often people think is a women's issue. We look at how we can address some of the power dynamics in health seeking and healthcare decisions, and making sure that not just women, but young people too have a voice in their rights and their health.
I have a question about this, Mesfin. When you look at this issue of providing help across boundaries of wealth, very often we're talking about resources being galvanized from the G20 countries and into the Global South. there's a question of respect for different approaches that people take in different countries. And in a sense, this interaction between G20 countries and countries in the global South could be tinged with a kind of neocolonialism, as opposed to an approach that is taken and embraced from the inside of a country. How do you navigate this very fraught terrain in a way that gets the healthcare to people that Traci is talking about, but also is accepted and embraced as a respectful articulation from one person to another, as if we are all members of the same family, but maybe living in different houses? How do we get there?
Yeah, thanks, Mark, for having me in for this question as well. And certainly, Traci outlined, the gender and dimension of health. But I think, as you have outlined, there are, societal and cultural factors that determine the possibility of people to access health care. And global health is global. We all are in the same village. A disease that emerges anywhere in the world that can affect anyone. I mean, COVID is a classic example that a virus can travel throughout the globe in a matter of, days, not, months, as used to be, during the first influenza pandemic. So I think we need to embrace that, we are dealing the same situation together. And certainly we need to be respectful as well, each of our differences. We all come with different cultural and societal, background. In some situation, in some places where we work, IRC work in fragile humanitarian settings, even the gender, the social group of healthcare providers, and the belief associated with it actually can impact in terms of access to health service and how people judge whether the service is accessible to them or not. For example, a society that forbid, casual physical contact between unmarried men and women would reduce accessibility of health service for women. So, you don't need to go anywhere further than Afghanistan, and where I worked, in my earlier days of the career, that you can't, expect a woman to go and seek health service from a man provider. So means that you have to look at.
In that sense, you would be incompetent because of the cultural context to provide certain services that a woman in Afghanistan would be able to provide. So that sort of collaboration and respect for that culture leads you to provide your services in particular ways.
Yeah, so understanding those cultural dynamics, and even though we are international organization, majority of our staff are local, and we hire Afghani healthcare workers and social workers to provide the service. So we need to provide opportunity for women healthcare workers to provide care for women who are seeking care. And in today, Afghanistan today, women are not allowed to work. That is a big threat for women's health in Afghanistan. And we as an organization, we advocate strongly that this policy is actually harmful to health of women and girls. So allowing women healthcare providers to provide those services is essential for accessibility and acceptability of the service. So as an international organization, we have a responsibility to understand those cultural dynamics, help people to gain control of their health by facilitating that health workforce development that respect the culture, and of course ensuring that they are supported with the resource that is needed. That's where I think that the point you mentioned about G20, who have the resource to be able to help Afghanis to have a basic package of health service. Today the Afghanis are suffering from sanction. And although, sanctions are blunt instrument, it doesn't really serve intended purpose. Who are suffering at the end of the day? It's the women and the girls who are needing the health care. I think we need to find a better way to reach to those people with the resources that are available.
But Mesfin, we have this issue right now in which women are not allowed to interact now with foreign aid workers, including healthcare workers. How, Dennis, do you get to the point where you're able to bridge these kinds of issues? Because on the one hand, the view of the Taliban is that this help is an attack on their culture, right? On the other hand, so they're cutting off these interactions. On the other hand, if you can't have the interaction, you can't help, right? And so Corus is not going to invest money and time and treasure in a place where you're just being blocked, as tragic as that might be. You can't come in with the Corus army to force people to take your help. How do you navigate that kind of terrain?
Yeah, thank you so much. And thanks to Traci and Mesfin as well, who have clearly articulated about the cultural, social dimensions under which we operate. And I think that is a reality we have to accept. To begin with, I think building trust and acknowledging that these cultural aspects not just impact the way healthcare services are used, but also in the way providers can interact with aid organizations, or for that matter, provider acceptance in a country. So I think, first of all, trying to understand that social context and cultural context is extremely important. At Corus, we place like Engender and IRC as well, but our model of operation has always been working through local partners, and therefore who are vested and who knows the context, and which obviously gives you a greater entry point, I would say, in terms of faster acceptance of providers or the healthcare systems that you're trying to offer. And that's an important piece of how I think one could possibly navigate that. In my earlier life, like Mesfin, I worked extensively in Afghanistan as well. And one of the pioneering work that I always remember is we pioneered introduction of digital health in Afghanistan. In 2008, that was the first time ever women used or even had access to mobile phones. And they were trained and equipped in terms of using digital health to respond to child and maternal health issues. But the point is very clear. We were able to do that in a restricted context by able to work with local actors, advocating, influencing, and also finding a clear role for men in this. Men are often the ones who handle technology, but for them to be able to accept their women to handle technology was a transformation, including articulating a role for men in terms of how they can help.
Dennis, it strikes me that we're sometimes so blinded by our own context. If you take a look at how diseases spread and the introduction of smallpox into the Americas by the Europeans, the introduction of various diseases all throughout the global South by Europeans as they traded, right? And then you have the same kind of thing happening based in trade, right? Based in the fact that everybody's getting on airplanes from different places. And so diseases that originated in a particular place that it used to spread very, very slowly, right, is now spreading very fast. This is something that has been around for all of human history. And so when we look at it as if now suddenly it's happening to us, quote unquote, it's actually something that has always happened. And the same thing with our cultural context. I accept my cultural context as normal. You accept your cultural context as normal. Mesfin, Traci, everybody accepts our cultural context as normal. Well, what happens when all these normals interact? We have to develop a new skill set, don't we, Traci? You're on mute.
Thank you. I think sometimes we look at our cultural context and we think about the geography. Like I don't know the community where you grew up, Mark, or Dennis or Mesfin. And certainly my childhood in Southern California isn't applicable in the same way to the work that we do around the world. But I think the other piece that's so critically important is that we're bringing in communities and people to really speak for themselves, so that when you're designing programs to meet the needs of a community, that people with disabilities, people living with HIV/AIDS, adolescent girls and young women, that they're speaking, survivors of gender-based violence are speaking for their community. Again, it's not always geographic. Sometimes it's about the needs that a community or population has. And I think that we need to look at it from all of these different angles. And you're right, my own reality is only shared, perhaps by a handful of other people. And it's irrelevant. What is important is that people can articulate their needs, be asked about their needs, and go through and be part of a transformative process, really to query their own norms and work together with members of their community, whether it's geographic or otherwise, to evolve towards where they want to be.
So does your staff, Mesfin, and please jump in, does your staff?
No, I was gonna just say, following to actually Traci, outlining we all come with different background, but one thing is in common, human rights are universal and they are universal values. That's what we share together. And it is something that is codified through international instrument and also as a humanitarian organization. The standard that we use, like the Sphere standard, is basically inspired by humanitarian values and human rights values. So these are the common values that are universal. We apply everywhere we go. So that doesn't mean that we ignore culture, we ignore, societal norms. We respect that. But access to health service and anyone to give service with dignity, that's a humanitarian value. We cannot compromise on that. Yes, we need to help people understand what does means dignified, life, and for someone to access health service without being harassed or, discriminated. So I think we have a common ground that we all share. And if you agree on those principles, I believe we can travel a long way. And without necessarily, undermining, whichever culture we come from.
So what you're describing is a basis for cooperation across cultures, right? In other words, a shared value, a respect for human rights, a respect for the baseline condition of all people. And so what you're talking about, Mesfin, and I'd be interested in having you, Dennis, and you, Traci, comment on this. The whole idea of differently skilled people with different genders working together, different lived experiences. It was mentioned, for example, treating people with HIV or disability. I think, Traci, you mentioned that. Does that mean that staffs that you have on the ground it would benefit you to have people who have experienced HIV themselves, having contracted it? Is it beneficial to have people who have disabilities serving people on the ground who are disabled, people from particular geographies or communities or cultures being part of your Corus family, Dennis, in order to be able to then provide the medical services in a way that is culturally sensitive and is situationally sensitive. How do you feel, Dennis? And then Traci, if you could jump in, that would be great.
Well, thanks, Mark. Well, I think that is an integral part of how we operate in terms of how we staff ourselves. People of all backgrounds are welcome to work here, and I think they are best equipped and enabled to respond to the needs of those kinds of specific populations, whether it be LGBTQ or disability or other minorities. And I think working in a manner that engages them and effectively uses them to design programs can have greater impact. I remember my time when I worked on HIV programs, working with people who are living with HIV/AIDS. They have their associations in Ethiopia, for example. We worked with them and was able to have great impacts. In other words, achieve results more than the targets we said we would achieve. So I think equipping them, building their capacities are all integral parts and required for us to have any impactful health outcomes, I would say.
So in a sense, we're redefining the idea of competence, right? Competence is not just the technical piece. right? We have here two doctors, right? And then we have people who have different competencies. They might be finance competencies or communication competencies or fundraising competencies or logistics competencies. But we also might have cultural competencies and lived experience competencies. Is that how you see it? So we're not, when we're talking about diversity, we're talking about the ability to actually be effective within contexts, particularly international contexts. How do you see it, Traci? And you're still on mute again.
Off now. Well, I think going back briefly to Mesfin's point about our fundamental human rights, the rights of children for education, the rights-based approach to the work we do in contraception and family planning, for example, is absolutely fundamental. I agree. And I think part of that is, as you're referring to, Mark, making sure that we have the perspectives so we can implement and really achieve those rights. There are sort of the people who have who should have the rights, and then those who can get in the way. And we need to make sure that we're removing those barriers. In terms of, I don't know that we can hire staff that represent every possibility of health issue and lived experience, but we do, like IRC and Corus, work with partners that do have that experience. So, for example, in Tanzania, one of our key partners is CCBRT, which is a hospital that provides health and rehabilitation services to people in Tanzania with all full range of disabilities, and so they are our true partners in designing interventions and programs and services, and making sure that when we talk about accessibility and quality, it's from that perspective, a cohesive perspective, very rights-based perspective, but also really informed by people with the lived experience and professional experience. And then, Mark, also in terms of your point about competencies and all of the pieces required to do this work, yes, we need people who know logistics and supply chain management, and people who know the accounting and audit and the context, and whether it's through our staff, our advisors, our partners, and especially, I think, in the case of all of our organizations, the host government institutions where we're working, the ministries of health, the ministries of education, ministries of finance, and others. We can pull all these pieces together, and it becomes, really a beautiful and complicated and necessary tapestry as we pull all that into one place.
Mesfin, how do we get to the point where people are able to help themselves, where they have the infrastructure required? Because part of this response to emergency, which is part of what International Rescue Committee does, part of that doesn't structurally shift the dynamics. In other words, there will be another emergency and another emergency and another emergency. Eventually, we need to strengthen societies so that people can respond to their own emergencies. How do you ensure that after an emergency that you are leaving behind a system that is able to better respond for itself?
Yeah, I think as a humanitarian community, we have learned and evolved over many years. I think since the early 90s, of disaster response, where the model was to fly in a response team and then leave quickly. And now, people who are living in, everywhere, which are prone to disaster, with better training, preparedness, they'll be able to help, their community and themselves. And in any disaster, anywhere in the world, the first responders are your neighbor. Those are the people who come to the rescue immediately, whether that is immediately after earthquake. Today, in Turkey, thousands of people died or at least injured, and who are rushing to help is their neighbor. So I think, what we are doing is really to develop, either community-based disaster preparedness, helping, local actors to have the tool and the resource they need to prepare for potential hazard. And I think that is where we are making difference. Many countries have a disaster preparedness, department, although they may not be adequately resourced and capacity. That's where I think international partnership can add value to build local capacity. So that is the model, and through partnership with local actors, we can enable, local responder to be effective in their response to a disaster. But again, depending on the scale, no disaster, two disasters are always the same. Sometimes it's overwhelmed local communities' capacity to cope. So that's where I think outside assistance is necessary. And I think that is also complementary to local actors. And as always, we should always be starting, with rehabilitation and, leaving behind a strong, resilient system after our response. And that means that, training and working with local responders and working with the local system, and also ensuring that the institutions that are there are part of the response so that they'll be able to be, respond for future disaster when this happens. So that model of partnership is what is actually helping local communities to be able to prepare and respond to disasters.
Dennis, is Corus also paying attention to knowledge transfer, leaving people on the ground who are able to be those first and second responders, basically building up the in-country competency and ability to respond as well?
Exactly. That's how we also operate. As I said, our model has always been working with local partners, and I believe 99% of our staff are local. So in other words, we are identifying skilled people, enabling them, equipping them with the skills, and leaving them there itself in their own countries or regions so that they are able to, act whenever there is a greater need. If you take Ukraine, for example, all of our partners there are local partners. I mean, we don't have any expats working there, but have identified strong, capable local organizations who just need additional resources and skills, as Mesfin already alluded to. And so that has been always our way of working, and we continue to uphold that as the most sustainable and also resilient ways of, operating, I would say.
We're coming to the end of our time, and I just wanted to share a couple of responses that we've received to our polls. We asked, what is the most critical health challenge facing the Global South today? And we got two different responses that rose above the others. One was climate change, hurting food and water availability, and the other is corruption. Now, corruption is a very fraught topic because one person's way of operating is another person's corruption. How do we deal with these two issues in a way that that is realistic? Right? We cannot switch a light switch on and all of a sudden climate change stops. We can't deal with that. We cannot determine what somebody with how people in a different country operates. We can influence that, but we cannot immediately determine that somebody is going to operate the way we choose for them to operate. How do we address these two issues, which seem to be beyond any of the capabilities of your individual organizations to address in the short term? Societal change, definitions of corruption is again beyond your ability to address. How do we deal with this? I'd like to just do a quick lightning round. Traci, do you have an approach that you try to use on trying to deal with problems that are just intractable and long term?
So I would say there's a common, and at first I thought, oh goodness, a question about climate, the climate crisis and corruption, where do we go? We just, but I think that there is a common denominator. I think it's resilience. We know that more resilient communities, and as we support community and societal resilience, we can address better the climate issue. And we know that women and girls are a key part of that. We know that climate and all of the health issues it's not just intersecting, they are of one. But resilient communities and supporting communities to identify solutions, to be able to act on those solutions, and to be able to control the priorities and resources, that people will make the decisions that will help them address the effects of climate and also health. And I think similarly, health systems and other institutions and their resilience will help us address the broader issues around corruption. I think that when health systems, for example, have the tools they need to do the budgeting, the planning, the processing, the staffing, and can fairly recompense the staff, from community health workers to ministers, in an appropriate and systematic way. As those systems become more resilient, I think we'll see more consistency and predictability in their actions and decision making. So I'm gonna call resilience our common denominator there.
Resilience, and the way you describe resilience, it's basically power on the ground, right? Power on the ground. Dennis, I know that I was making these. One was a natural phenomena or a phenomenon of nature, right? But you cannot just change it immediately. Corruption is a phenomena of human perception, right? You cannot just change that instantaneously. Traci's answer is basically power on the ground, which she defines as resilience. Is that your view of what we need to do in order to respond, to make the world more able to deal with these issues? And rather than have, G20 countries sort of fly in and fly out, as Mesfin described sort of past approaches, do you see that as being the response?
I do. I mean, I think these are macro issues that are beyond the reach of any of us to respond in a very effective way, but we can contribute towards that. We all have employed, and right now we do employ in our projects an approach called social accountability, which is a bottom-up approach, making people aware of their healthcare needs. For example, what is the budgeting issues, and how can you work together to articulate what are the minimum quality standards you expect, and working with bureaucrats to make sure that I, as a client, get the quality that I deserve to get. So I think it is a slowly but effective mechanism that takes a bottom-up approach in terms of holding politicians and governments accountable or responsible for their healthcare services. So that's one approach that has worked. So I think we are small actors in this that is influencing the broader issues of corruption. But it is a time-taking process, is for sure. Obviously, there are policy impacts that we can influence as a result of these kinds of approaches that we are implementing. So I do see us as small change agents in the larger macro issues of governance and corruption. Yeah.
Mesfin, we're going to end up with you. You'll have the last word. But it seems that what Traci and Dennis are saying is that we need to have a process of bringing people into the tent of this solution, of this empowered group of people like yourself, who are bringing solutions locally. But then, as we bring people into the tent itself is going to change. And we have to be okay with that, right? We have to be okay with the fact that if we're including more people, we're including more voices, we're strengthening solutions, we're creating the resilience that Traci referred to on the ground and the capability on the ground, the tent itself changes. Do you see it this way as well?
Yeah, it is. Certainly we all have a role to play. I mean, these are, big issues, and it cannot be just left for a few actors. Certainly, taking climate change alone, we may feel powerless in the face of big polluters, and which would have significant impact in terms of greenhouse gas emission. But we see our role in terms of helping people even adapt to the changing climate, stressed world. So that is where our place. And yes, we can advocate for that emission reduction, which is absolutely important. There is nothing that's going to replace that. But we can help that smallholder farmer to adapt the climate change. Whether improving their farming technique, how they use, scarce water resource. And we see it, climate change is a daily reality for our client. It's an interface of conflict, displacement, climate change is accelerating that. So, the Horn of Africa, the last few years have seen unprecedented level of hunger and malnutrition, primarily driven by, climate change. So as a humanitarian organization, we have to be better in terms of efficient use of a resource, whether that is how we treat whether a malnourished child or deliver healthcare services, but at the same time helping these communities basically to adapt in this new reality. And the most important is that women are the majority of smallholder farmers, and those are the people who are child care provider and also the farmers. I think any woman-centered, a feministic approach to help those would have significant impact. So I don't see ourselves, the place, crowded. It's a big place. We have a role to play, but we just have to be clear what's our role, and don't to be paralyzed by a big problem that we cannot reduce 2 degrees centigrade or 1.5. And China and US have to agree. Yes, they have to. And that's important, but I have also a role to play. I think that's, if you play that one, we can have impact on our environment and the climate.
Well, I think the answers to our last question are very instructive in this sense. We asked, who do you believe is responsible to fix the health challenges in the global South? And we got 60% of the people said governments. The balance said people in the global South and people in G20s. In the G20s. So if you look at governments, people in the global South and people in G20, who's responsible for this? It's all of us. And it's all of us collaborating together. It's using the different competencies that we have, the knowledge that we have, the technical knowledge and the cultural knowledge. Traci Baird, President and CEO of EngenderHealth, Dr. Mesfin, Teklu Tessema, Senior Director of the Global Health Unit of the International Rescue Committee, and Dr. Dennis Cherian, Associate Vice President of Global Health and Nutrition of Corus International. Thank you so much for helping us to understand the work that you're doing. Please thank your colleagues, your boards, your staffs, your volunteers, the people on the ground, and the people who are in the central office who collaborate together in addressing these so important issues. And thank you so much for sharing your insights with us.